lots of them keep maturing without any ovulation. And so with time, they now form cysts.
Hi everyone, welcome back to my channel. What is our discussion all about today? PCOS. PCOS. What is PCOS?
Thank you very much for this question. So PCOS, otherwise known as Polycystic Ovarian Syndrome. Some people like to call it PCOS. And so from the word polycystic, it means, poly means many, and cystic or cyst means a cyst. And so it's basically it's about the most common endocrine disorder in reproductive age women worldwide. And its prevalence actually it's estimated to be about 5 to 15% worldwide. So it's actually very common. In about 15% of female population to find this disorder. The cause is actually multifactorial. It ranges from genetic. So there could be genetic risk factors, which could be either first. So it could be genetic. It could be, there are also environmental influences as well. And then, so that's also a risk factor. And then so basically, polycystic ovarian disease is just a disorder, an endocrine disorder, or a metabolic disorder, no, not metabolic, endocrinological disorder, where there are lots of cysts in the ovary. Yes. And if I would go ahead just to maybe give a little analogy of how it comes to be, in the brain we have the hypothalamus, and then we have the pituitary gland. The pituitary gland has the anterior pituitary and the posterior pituitary, right? So usually gonadotropin releasing hormone is produced in the hypothalamus, and this works on the cells in the anterior pituitary gland to produce two key hormones now. I would say luteinizing hormone and follicle-stimulating hormone. Now, follicle-stimulating hormone actually goes down from the pituitary through the bloodstream to the ovaries, and then it makes the ovumes. Now, the ovumes are the eggs, if I would say so, or the cells rather, inside of the ovaries. So it causes them to mature, it prepares them for ovulation, or use that word. And so, then when this follicle or this ovum becomes mature now, the normal thing is that after every 28 days, because the menstrual cycle, it gets shed off, as what you would call menses. And then when it's shed off, the remains in the, it releases, it's encapsulated, right? It's covered, and so it releases the covering, it releases the egg as menstruation, as the ovum itself. Meanwhile, the body that houses it stays back in the ovary, giving rise to what is called a corpus luteum. And this corpus luteum now produces progesterone. So it produces progesterone. This progesterone now has a negative feedback to the brain, telling the brain, okay, the amount of luteinizing hormone and follicle-stimulating hormone you're producing is enough. Please reduce or shut down the production. So that's how the cycle goes. So progesterone actually has a negative feedback effect on gonadotropin-releasing hormone to reduce it, and it just keeps it in check. It's kind of like a cycle. All right. So, but in PCOS now, in this disorder now, there is the follicles actually don't ovulate, meaning they don't leave the ovaries eventually, and so this becomes problematic. Now, see how it goes. The follicles don't shed off. The gonadotropin-releasing hormone from the hypothalamus is still secreting, telling the anterior pituitary, hey, pump more luteinizing hormone, pump more follicle-stimulating hormone. and it keeps pumping and pumping and pumping. And meanwhile, it goes to the ovaries, and the ovaries just keeps producing lots of matured follicles, and so it keeps producing them. Meanwhile, the lady is not ovulating. So these follicles just keep maturing. Lots of them keep maturing without any ovulation, and so with time they now form cysts. So that's why you have the multicyst or the polycyst actually. So it's called polycystic ovarian syndrome.
What are the symptoms of PCOS?
Oh yeah, sure. The symptoms. Thank you. The symptoms of PCOS are you could have, just like what I was mentioning earlier on, there's anovulation. Anovulation, it's a kind of situation whereby, or a conflict, just basically that the lady does not ovulate. So there's anovulation, anovulation and then menstrual irregularities, kind of like more of chronic menstrual irregularities. Not just, oh, I didn't have my period for like 1 or 2 months, but then about 6 months at a stretch, that long, not just a month or, yeah. So many people have this symptom, and also there could be because there is weight gain actually, because one of the people affected by these disorders, they gain a lot of weight, and so they are obese or they are actually on a large size, and then we could have hirsutism, that's abnormal distribution of hair, and also acne or pimples, what some other persons might call eruptions, and then also it could be alopecia, loss of hair on the head as well. And and of course, if you should do, well, those are the symptoms, right? And then if you go ahead to do a scan, an ultrasound scan, there you will see the cysts actually. You will find them, or you just see them, like you see the ovaries and then the cysts all inside the ovaries like that. You will see them. And so these are some of the, and of course, because clearly you can see that there is an hormonal imbalance. Because of the progesterone is not being secreted, which does not give the negative feedback to the hypothalamus to slow down production. So that already creates kind of like an imbalance of hormonal interactions, and so that brings about the menstrual irregularities. And of course, if a lady does not menstruate, she can't get pregnant. So there's infertility also. So some persons you find, or some people, they come to the hospital, they come to the clinic, and then they're trying to get pregnant. They're not able to get pregnant. This is one of the things to actually look out for, because I know it's a very big concern these days, and it's actually one of the PCOS is actually one of the it's actually the major endocrine disorder in females, and so you can tell that lots of infertility cases, are a result from PCOS. So it's very important in our time. And in these days where we're actually finding actually 15% of the population is actually much for any disease or for a disease. It's actually much. It's something to watch out for. Yes. And so basically, infertility, there are issues with hormonal menstrual irregularities, and then there are acne, eruptions or breakouts, and then abnormal distribution of hairs. You find females having the male kind of hair patterns. Yes. And so these are some of the symptoms that you find in PCOS.
How is PCOS diagnosed in the clinic?
Okay, thank you very much. Diagnosis of PCOS is actually a diagnosis of an exclusion, or So it's a diagnosis of exclusion, right? Meaning that you have to rule out lots of causes, a lot of things. You have to rule out so many things and then come to arrive at PCOS, or to come to arrive that, okay, since it's not this, it is not this, it's not this, I've checked for this, it's not this. We ruled out all the possible causes of what could be causing infertility, or what could be causing amenorrhea, what could be causing the breakout or the acne, what could be causing the hirsutism, what could be causing the menstrual irregularities. By the time you rule out all those causes, then you'll land at PCOS. And some of the things we usually rule out. First of all, when a lady is not menstruating, we want to do a beta HCG that to check if she's pregnant or not, because pregnancy, yes. So you want to rule out, okay, this lady who is not menstruating, is she pregnant or she's not pregnant? And then also you want to check the kind of if the patient is on medication. So if the lady is on medication, is she on some androgenic steroids that could be causing the cystocin, that could be causing the acne? You want to check that, and also the weight gain. Also, you want to check, okay, is she on any drugs, such as maybe some dopamine antagonist drugs? And also, you want to you would like to do a thyroid, do a test to check for thyroid disease. Yes, because the weight gain she might be encountering, you want to check, okay, could it be a thyroid disorder, or could it, you want to rule out. So it's a diagnosis of exclusion, and also you want to check for a high range and a low range. So you want to check for the FSH, that's the follicle stimulating hormone, the luteinizing hormone, to check if is there any hypogonadism. Could it be that the gonads are affected? Could it be a primary disorder or a secondary disorder? And then also I want to check for okay. And then also, yes, and of course you want to do a scan eventually, to an ultrasound scan. When you do an ultrasound scan, you will just see the cysts in the ovary. And so usually in the hospital, when you've excluded other causes, then there are two criteria we use to now bring all our rule-outs to the course. So there's what we call the Rotterdam criteria, or the androgen excess society criteria. But usually we use the Rotterdam criteria. And so the Rotterdam criteria, it just says that it has three possibilities, and it says that if two of these options rather are present in the female, after you've ruled out all other exclusions, it then means that you're dealing with the PCOS. And so one, it gives menstrual, if there's menstrual irregularities, either oligomenorrhea or amenorrhea. And then there is also you want to look out for hyperandrogenism. And then you look out for polycystic ovaries through a transvaginal scan. It gives a higher resolution, and so it's more preferred. So if there's a ultrasound scan, and you find polycysts, you find so many cysts in the ovaries, then if there are menstrual irregularities, if there are hyperandrogenism also. Hyperandrogenism, what I'm looking out for there is basically the histocystine, because that brings about the excessive hairs that the female might have, and also the acne. So if either two of them are present in the lady, then you are certainly dealing with PCOS. And that is the Rotterdam criteria. The other criteria, the androgen excess society criteria, is not really so used, but for that one, it's the three. It says if there is if there's hyperandrogenism, if there is presence of menstrual irregularities or polycystic ovaries. Now, in the Rotterdam criteria, it says there might be menstrual irregularities or polycystic ovaries. I don't know if it's basically they're about the same criteria, because they have different value. Just that in the androgen excess society criteria, it just says you have to rule out other causes before you come to this diagnosis. Yes. And so pretty much that's how we diagnose PCOS in the hospital.
How do you treat PCOS? What are the available treatment options for PCOS?
Okay, the treatments for PCOS. Okay, thank you so much. The treatment for PCOS, it's basically, I would say, lifestyle modification. That plays a huge role in the treatment of this disorder. And so lifestyle modifications, I'm talking about dieting, calorie restrictive, so smoking cessation, dieting, and then exercise. These are three basic non-pharmacological treatments actually. Because for these ones, you don't need drugs. Yeah, you just restrict high calorie or foods with high calorie, and then exercise also. If you can achieve good exercise, weight reduction. If you can achieve smoking cessation for people who smoke or people who are around people that smoke, that goes a long way. And then dieting. I actually have a friend who she's a dietitian, and she has classes, or she has talk shows about dieting. So dieting, she treats people with PCOS by dieting alone, and it goes a long way to alleviate these symptoms or this disorder. Then for treatment, also when you go to pharmacological treatments now, we're looking at two things now. We're looking at, is this a lady who plans to get pregnant, or is this a lady who is done with pregnancy? What I mean is that the treatment options available are either ways, either for a lady that wants to still get pregnant or is planning to get pregnant, or a lady who is done giving birth. There's some treatment. Usually we use drugs. We use clomifene. There's a drug called clomifene, and then letrozole. So letrozole and clomifene, we use those drugs because these drugs, either of them, they help to increase ovulation actually. So these drugs now, for those who still want to get pregnant, they help them to ovulate actually. And so once the lady ovulates, then corpus luteum is produced, and then corpus luteum now produces progesterone. Progesterone is the one that actually goes back to shut down the levels of LH. The levels of LH, that's the luteinizing hormone and follicle-stimulating hormone. And so these are the treatment options available. Something very important, maybe to note that LH is responsible for androgen synthesis in the theca cells. Theca cells are just a group of cells you find the ovaries. So it causes androgen production to be increased, and of course, androgens are just for a very little amount.
What are your chances of conceiving after treatment of PCOS?
Okay, thank you so much. Yes, it's to a good extent, because PCOS is treatable, and yes, we can recover from it if she goes through the treatment plans and options, both the non-pharmacological and the pharmacological. Yeah, it's very possible it's very possible to recover from it. And many people who have had this disorder, although it has to be managed, it's not something that it's something that could be managed, that is managed. So the drug treatments are taken for a long time, and also the non-pharmacological treatments also should be adhered to. Yeah.
All right. Thank you so much for that.
You're welcome.
Thank you so much for watching this video.